So I'd like to say thank you again to all of our panelists for sharing your experiences, your opinions, and the questions that we're still charged with. And at this point, I'd like to open this up to others in the audience who may have questions for any of the panelists. And again, if you can just give your name and affiliation when you come up to the microphone. Steve, I think you're going to lead us off.
Thanks for a great panel, Steve Jaffe from UPenn. Question directed to Gail, although others can take a stab at it if they want. Gail, as you know, and as you and I have talked about, figuring out your list of 56 genes or 120 genes or whatever it may be is actually the easy part, and deciding which variants you're going to call as likely or expected or known pathogenic within those genes is the harder part. And your VUS example is an example of how difficult that can be to do. So my question to you is, what would it take for an investigator who wants to comply with the sort of guidelines that your paper is going to come out with to be able to actually implement that? What would he or she need to build either within the research team or outsource or contracted or through consultants to actually be able to do that sort of variant calling, particularly with novel variants or ones that aren't, the small subset of well-known variants that everybody could sort of call with their eyes closed?
Yeah, that's a great question. I mean, I'll start by saying that when we get clinical reports back, we often disagree with the way the variant was called by the clinical lab. So they'll call it likely pathogenic and we'll think it's benign. They'll call it pathogenic and we'll think it's a VUS. They'll call it a VUS, we'll think it's pathogenic, because we go back and look at the literature. And it's something I've worked hard with the genetic counselors, that when you get a lab report from a lab, you don't just agree, it says likely pathogenic, here you go. Because these are not easy calls, actually, and you really actually have to read the papers. So it's not a simple thing to annotate. I think that part of stumbling upon a finding is you have to stumble on something that you know is bad. So I don't think that you're obligated to say, well, I've sequenced BRCA, I'm going to hire out someone to comb through it and see if any of those variants are mutations. I'm much more concerned about the scenario where we have a prostate cancer study, this is a real example, who then sees, oh, a bunch of these families have a lot of breast cancer too, tests them, finds BRCA mutations, and doesn't tell anyone. So they know there's a mutation, they just have elected not to tell people because they're consented to not get genetic results back. So I don't think it's easy to decide whether something's pathogenic or not. I think ClinGen will go a long way towards what we know is pathogenic and putting it all in one place. But I don't think you actually have to do a lot of work to figure it out. If you don't know that it's pathogenic, your job may end there.
And can I just ask one follow-up question, which maybe is implicit in your answer, but to what extent do you actually need information on phenotype, family history, et cetera, to be able to interpret the variant information that you have in front of you?
Yeah, another great question. So if you have a variant that is known, that is out there, known as a pathogenic, and it's clearly established, not just in like 2 papers, but it's a pathogenic, then the family history information doesn't necessarily matter, right? We see a lot of BRCA positive people who have no family history, and we have found BRCA incidentally in people with no family history of BRCA. We would still return that. It's when you get this expected pathogenic, likely pathogenic category, then if you have a family history that's consistent with that disorder, that can be extremely helpful. And that, when I said in my talk that some of these likely pathogenics for incidental findings in a clinical context with that indication would be considered pathogenic, that's what I was talking about. That context does matter in, is that the final straw to believe that it's a pathogenic mutation? It's helpful to have that information, but not absolutely necessary. And if you're limiting yourself to returning things that are known to be pathogenic, then it's not critical.
Sharon Terry, Genetic Alliance. So my disappointment in the ACMG report was in the process that they didn't have people like me who are members of ACMG but not looking at it from a medical actionability point of view participate, and then also in what they called. But my question to you all would be one that I've asked Ellen many times but not in any recent years. A lot of this is based on what is considered actionable in a medical context, but we know that people desire and actually value information in different contexts. And the example I would give is my children 19 years ago were diagnosed with a condition that still has no medical actionability. But because we know that, we've been able to create a cohort of 4,000 people who are well characterized and instituted about 130 experiments that were including clinical trials, et cetera. So there's been social value to knowing. And there's also been some value to them and to the other people that they're part of a community working toward this together. There's lots of other examples from families who do family planning or other things that aren't related to a medically actionable issue around a pathogenic mutation or mutations. So what about expanding that concept and not limiting it to just what's medically actionable?
I think there are two questions. So I have no general issue with people giving back everything. I don't see any problem with that as long as the person getting it has been educated in a way that they understand what they're going to get and then what they got when they got it. My question is really limited to what are we obligated to give people back? And I think when we talk about what we're obligated to do, that we have to think about what the cost-benefit analysis is. And so I absolutely agree. There's personal utility, and I see a lot of people who get genetic tests for conditions that are not treatable, and they still want to know. They want to plan their lives. They don't want to wait till they have symptoms, and that has a high value to them. The question is, what is the cost-benefit analysis in a, and I'm talking about a research setting, different than clinical setting, of are we going to give them back things we stumbled across that are not treatable in any way? And so we were really trying to understand, what is the floor? The floor is actionable things. What is the ceiling? The ceiling was everything. And I agree that there's a lot of definitions of utility.
I would say what she said. I think I think the thing that we have to ask is, what do we think comes within the scope of what the research enterprise, must involve? Because there's no question there are not insubstantial costs to following this up, to returning the information, to the downstream costs, et cetera, et cetera. And I think that we just need to have a robust debate in our society about, what the research enterprise comprises or not. But I think the reason that so many people go around the clinical actionability, I think is because it just seems like the risk-benefit, particularly the benefit ratio, is so much different in that setting. But I think I think that's a social values question and what the trade-offs are going to be. I think that's all.
Jeffrey, you had a question?
Yeah, Jeff Botkin from University of Utah. This is for Jeff. It seems we have a fair amount of literature on how people respond to questions about would you want to be consented or would you want a choice around certain biorepository uses, et cetera. And the answer is pretty consistently yes, although I think one of the themes in the literature for many years is that hypothetical questions oftentimes get different answers than real questions. And I think we have a fair amount of information about how people respond to consent documents and consent choices, sort of at the front end of a research project. I don't think we have very much information about how people respond to the dilemma that you posed for us, which is they were in a research project, they signed a certain consent form. Now you're thinking about using the specimens in a way that wasn't entirely anticipated. What do we do with that? And I think it's a legitimate question. So my question for you is, did you think about actually going back to those folks on a, not a uniform basis for reconsent, but on a focus group? Pull together 3 groups of 10 people, which is not insignificant in terms of cost, but it at least would give you a reflection of how those folks would be thinking about the dilemma that you then could turn around and take to the IRB. And I would guess, my assumption is a lot of those folks, and the majority would say, this is a no-brainer, and that you would potentially have that leverage to go back and say, here's how we'd like to manage this information. I don't think there's been much literature on going back to people who've already participated is the point.
I actually, the lines I was thinking are similar, was that to ask that specific question, the broader question, although not to the group of people that was most relevant to, I think that's a great idea. I'm not sure the feasibility of it. In one of those cases, the gastric cancer trial, I don't think it was very feasible, unless you could reliably know that as you're reaching out, you're going to hit the people who are still surviving and in follow-up. I wouldn't want to send random letters out to the family members. But I think there's definite need for research in the public around the exact questions we rest with. You know, people gave their biospecimens, they consented to future unspecified research, but now the concept of data sharing is posed, or some expansion is posed. Which side would they like the scientific community to be erring on? And what are the contextual factors that influence that? Because there's probably not the same reaction in all settings. So I think that research would be great to see move forward. I think the idea of doing it in the real world context of this is the exact group, let's ask them, so it's even less hypothetical, would be fantastic. But the answer is no, we didn't think about doing it then. And we potentially could for the adjuvant trial, actually. Yeah.
And to add that we did the group health cohort was reconsented. It's the one Brad described this morning, that the average age was like 89, and there were all those 89-year-olds messing up his privacy rule. The IRB did actually require us to go back, even though we were doing a genomic study for similar indications. I still don't agree, but it was interesting. We reconsented them for data sharing so that we could db-GEP post. And then we also followed it up by a survey of what their attitudes were. And Sue Trinidad wrote a really nice paper that I think was in Science. It was called Glad You Asked. So fundamentally, as Ellen said earlier, we had about 86% of people who said, sure, fine, do that, do genomic work, post the data, that's fine. Keep in mind, these were very frail people, so a lot of people who didn't consent might have consented, but it was a dementia study, so it makes it a little more challenging. So that's a pretty good return. We had normal controls too. But people really liked having been asked. That said, would they have said, go ahead and do it anyway? Yes, I think they would have said, go ahead and do it anyway, even without asking, because they really wanted the problem solved. That's why they enrolled in the research. One of the interesting things, I've actually reconsented several cohorts. The older individuals are, in my hands, you know, with like 3 studies, more interested in data. They don't care. Take it, publish it, give it to your brother. I just want you to fix this problem, and they're not so worried about privacy. And it's interesting. We had the conversation this morning about the Facebook generation, but those people actually do think about privacy, possibly more than by the time you're 90, you've gotten the diseases you're going to get. There's not a secret in your genome hiding anymore. So there's less of a concern. So there's a lot of context around what people want, I think.
We'll take another question at the far microphone.
Yes, Roy Herbst from Yale. One thing that's happening now is there are clinical trials being developed using next generation sequencing where you might find 3 or 4 or 5 potentially actionable mutations or alterations in a patient's tumor. And then they're being placed on clinical trials, maybe 3 or 4 trials that are grouped together. And the question I have is, if we use that information and we decide to assign the patient to one arm when they might be potentially eligible for 2 arms, do we have to let the patient know that they had those 2 alterations and have them involved in the choice, or is it reasonable just to randomize given that the data are equally marginal for the 2 markers predicting response?
You're asking if the patients should have more say in how the trial is
Well,
designed?
if there should be full disclosure at the time of a randomization. So if you're doing a clinical trial, let's say you want to look at HER2 mutation, a PI3 kinase mutation, you have multiple arms on a trial, and what we're finding is these mutations are not all mutually exclusive. So a patient might have both. So the way I would propose to do it is you would just randomize, but there has been some push in some of these trials that the physicians or the patients want to know how that's being done and have that information up front.
Yeah, I mean, so I think you can do it either way, right? If you're operating, everybody's getting standard care and everything else that's going to be added. So there's no, if they have a HER2 mutation and they're in a disease where it's established that HER2 targeted therapies work, obviously you have to give that. But if you're now building outside of standard care, I honestly think you can design the trial either way, and there's pros and cons. There may be more appeal in terms of accrual to your physician colleagues if they're going to get a little say, although I would argue we're usually not as smart as we think we are, and it's probably better to have the design where it's not controlled by me as the individual doc. Let you do the research in those areas that are not yet standard.
Well, I would agree with you. Then the second follow-up to that is, then the patient goes on study, and these are survival trials. So the patient progresses. Do you make that full sequencing information available to the patient at that time, or do you say because it's a study for survival, they should go on and do something else?
I'd sort of defer to the comments that were made earlier that if it's not my bias is very strongly that if something is not ready for the clinic, it's not ready for the clinic. So I don't feel, not only do I not feel we have an obligation to disclose things that sure, an individual may want to know, but we're not really sure what they're going to do with that information. I think actually it can be harmful to do that. So it's not to preserve the scientific integrity of the trial over the individual's interest. It's more that I don't think the individual actually has a strong interest in having that information until there's a clinically actionable consequence.
Thanks.
Patty Gans, UCLA. I have a question about archive specimens from deceased individuals, which is, again, our cooperative trials groups have plenty of those available. If you are deceased, you are not a human subject. What do we do? Can we use those specimens if, with going through the nice review that Jeff has shown that the patient did consent? Should there even be any question? I mean, clearly, those individuals have nothing to lose. They've already lost their lives. And so why isn't that something that we couldn't use for future information that would be valuable? With they're annotated, we would have important, valuable data that could be retrieved from that.
I mean, I'd have to think about it more. I guess my gut is that if they didn't, if they gave it with some form of broad consent, just like we thought for the people we couldn't reconsent, that it's fine. And in fact, I didn't present, there was another example of a pancreatic cancer trial where really that was the case, where we decided it wasn't need for much discussion. They'd consented to broad future use, wasn't perfect by today's standards, but we can use it. But if they hadn't, if you just happen to have them archived and you had very limited informed consent, even though the patient is deceased, and I think it'd be my gut is that it'd be a large violation of the trust that they placed in us to then just say, we have it, we can use it now. I don't know if others have a different opinion.
I think pathology departments, though, use archive specimens for test development and all sorts of stuff. I mean, again, I think it's, again, a hidden treasure, if you will. I doubt that there are too many trials that we have where we collected pathological specimens where we didn't suggest that it might be used for future research. I suspect that most of those trials will have something like that in there. It may not be genomic or genetic.
Two things. One of them is that Susan Wolf has an article about this that appeared in the last month about use of samples from deceased subjects. And I can't remember exactly what her final punchline was. Jeff, do you? But you might want to look at that. I think that I think there's not a legal impediment. I think you just have to be thoughtful at the front end about how you're going to proceed, and particularly if you think you're going to go back and talk with family members, then you better do something before you start. I'm
really looking at genomic or pharmacogenomic or some looking at a toxicity of a drug or a benefit in terms of some pathway that we might identify.
It honestly seems to me like the answer to that ought to be pretty clear. I am almost certain it's contested.
State law may also apply in Washington State. Dead deceased people are considered human subjects by state law, which was very unfortunate for us.
Hi, Carol Weil, National Cancer Institute. When you're talking about returning incidental germline findings in cancer, it prompts one to think about whether there's ever an ethical obligation in a clinical trial to invite people to list family contacts in the event of death. And I wondered if any of you had thoughts or comments on the wisdom of that approach.
Yes, so we actually specifically consent people because our patients have cancer in our trial, for if something happens to you, would you like to specify one person, not necessarily a family member, often though it turns out to be the spouse, to get information that we find after you're deceased. So we specifically ask the question and let them decide whether they want us to do that and who, one person.
One person.
I'll say something slightly ironic about that, in the sense that I know someone is going to ask me a question tomorrow about tissue that is in that the spouse has, and that the children or other relatives can't get access to because the spouse won't make it available. because the one person who's not genetically related to the patient is the spouse. I mean, it's a really interesting set of conundrums. I mean, of course, in our society, your spouse is the one who trumps, but it's a pretty interesting question.
Well, and it gets more complicated when there are stepchildren and issues like that.
That's my point, yeah.
So we actually do point out to the subjects that their spouse is the one person not genetically related to them, but nonetheless, that's their choice.
Deborah Collier, Patient Advocates in Research. And it's been a fascinating discussion. There are a couple comments and then I have a question. One comment in the discussion that I think is important for us to distinguish, because we're kind of using the terms the same way, but they mean very different things to people, is data sharing versus return of results. Those are two totally different concepts to people. Maybe not in the way we're discussing it in research, because you have to consider both aspects, but I think it's important to separate those. And then I guess the other question I have is, we're talking about the protections both Ellen, you and Jeff brought up, and I think both of you know how I feel because we've had discussions about this, about the protections that we need for people of misuse of the information. Because we talk about discrimination and being able to collect the information. The fact is, and we heard it again this morning, we can't keep people from collecting this information or getting information in some way that they're not supposed to get. But we can directly penalize them for misusing that information. And so my question is, why is this something that we seem to discuss within the research circles? How could we make this happen for all of the data that's applied to someone? Because frankly, to a person, they don't really care if this is in a research bank in XYZ university versus PQR. They're going to want whatever data it is that's going to be shared is what they're talking about from them as a person. So it doesn't really matter to them whether it's clinical data only or research data, or if it's clinical data that's been de-identified that can be used for research, or whatever kind of categories we want to put it in to feel comfortable. It doesn't matter to them, I guess is what I'm trying to say.
I think you're exactly right, and I would make the point that that one of the things HIPAA doesn't do for clinical data is give the individual patient a right of action. So the federal government comes in and prosecutes misuses of clinical data, but the individual whose data has been misused can't sue him or herself. So I think what we really need to think of, as you well know, Deborah, I've been singing this song for a while, that I think that we really, really need to pay attention to data security. We need to pay attention to data oversight. And I will pick up on Sharon's point here and say that there was a huge process problem with ACMG, and that we need to have evidence-based practices that that pay attention to all the various impacts of way information are used, et cetera, and that means being open to a variety of inputs. We just need to take this more seriously in the research enterprise, and then so what we do at Vanderbilt for our data is that investigators use this data, and they sign a data use agreement. We haven't had any problem with this, but if somebody violated the data use agreement and tried to re-identify a subject, they would lose their job. I mean, everybody knows this, and it hadn't happened. And so it's really important that we pay attention to the security, to the oversight, to the accountability, to the transparency, to the penalties, all of that. And it needs to be true not only in the research enterprise, but the clinical enterprise. It's just, that's what needs to happen.
Rich Shilsky from ASCO. I guess I'll address this question to Jeff. What I'm struggling with is the notion, excuse me, that I think you brought up of reconsenting patients who previously had consented to the unspecified future research with their specimens, because you gave a number of examples, and for some of the examples, you sort of had the caveat of, well, this form wasn't written the way we might have written it today, and so on. But it was written the way it was written at the time that the patient provided the consent. And the consent said, I consent to the future use of my specimens without specification. And so do we have an ethical obligation to apply the standards that existed at the time the patient consented, or the standards that apply at the time the new research is intended to be done in determining, whether or not the patient consent was adequate?
All right. Well, that's one of the key questions. And again, I have my feelings. I'd like to know more broadly. That's one of the questions I'd like to ask in a survey of patients, participants. I think, to be clear here, if the informed consent document had, do you want to give your specimen X, and then it simply said, do you consent to any broad, unspecified use, end of discussion, we'd actually have less issues. The problem, of course, in these cases, and I didn't go into all the details, was that in the 10 pages of verbiage, there were things implied about qualifications, and it will or won't be used in this ways that let us, as we went through as a committee, and people, of course, had different perspectives, have more or less comfort with this idea of general use. So it wasn't, I think you're exactly right. If people just said, use it, then what are we discussing here? But of course, that's not we didn't, even 10, 20 years ago, we didn't ask it that way. Maybe we should in the future.
I want to offer a suggestion that may help with this issue, which is, to some extent, these questions come back to the IRB, composed primarily of professionals, people affiliated with the institution, often a couple of patient representatives or unaffiliated representatives. But the question is that the best body to make this judgment? Okay, I've got this consent form that's 10 years old. Now we're thinking about this use that wasn't even contemplated at the time that the consent form was written. How do we reconcile the two things? And I have to say that I would feel more comfortable if the decision-making, or at least the advisory function, was driven by a committee that was composed of people who were explicitly representing patients, families, et cetera, who could put on that hat, I think, a lot more comfortably than IRBs can put on that hat, and make a judgment. Is it reasonable, in light of what this consent form said, in light of what these patients agreed to 10 years ago, to contemplate using it for this novel use?
Well, I agree, and although actually in these cases the IRB ultimately is the one who I think had the authority, but our committee, for that reason, was comprised of numerous, not just Deb, but other patient advocates as well.
Well, and actually,
before you talk, Deb, this gives me something to say about Jeff's comments. I think we actually have a lot of perverse incentives in the IRB system right now, and extremely risk averse in general. And I agree with you, Steve. It would make much more sense to talk with real people about what they actually think about it. But I mean, we really need to we need to change the incentives dramatically, or we're not going to make any progress.
well, and as a follow-up to that, it's my personal opinion, but it's founded on many different conversations with patients and patient advocates through the years, is that I think what we've got here and what we're discussing and trying to deal with is an artifact of the paternalistic protection culture that has developed in this area. And from a patient viewpoint or a patient advocate viewpoint, by specifying so many things in the informed consent form or in that particular circumstance, you're asking people to theoretically decide how they would feel about this category that they may not have a clue what would be involved in that, because we can't even tell them, right, in the future. And so it actually would be easier if we had simpler choices for people to make, or simpler descriptions of some of the research. And that may sound heretical coming from a patient advocate, but the fact is, a lot of people are making that decision of, do I want them to use this for later or not, period. Because they have no idea what it means, all these gobbledygook words that are included in the consent. So, maybe we need to rethink this again, rather than having a regulatory focused system, have a patient focused system, and figure out what that means and how can we do our best to protect people, but allow them to make choices that make sense for them.
Other questions? And if not, I have one real quick for Gail. I think that the paper that will be coming out, what you presented today from Emerge and Caesar, will be very helpful for research programs and thinking about where the boundaries are. I think that guidance is incredibly helpful. For those programs, and I didn't hear this in what you presented, but it might have been part of the discussion, for those programs who may have had consents many, many years ago, was what was in the consent form about return of results part of that decision about obligations, or is there an obligation even if the original consent was that results would not be returned?
We didn't address that specifically in this paper, but there were a lot of side discussions about that. And fundamentally, the sense was, and Ellen can correct me because she's in some of these discussions, that if the consent was that nothing would go back, then you didn't have the obligation to try and change that, but that going forward, the consent forms should have that open as an option, and that there was a very favorable attitude towards reconsenting people in ongoing studies where you thought you might come across results. It's quite rare. I mean, I want to emphasize that, even though if you comb through a whole genome or exome, a few % of people will have something. It's actually quite rare to stumble across something that's not the primary goal of your research. And, I've done human research with genomics in many, many contexts and have only had, one example where it was actually looked for, something that wasn't, that I thought probably should have been returned and the people weren't consented for it. So it's not something that happens commonly, but you don't want to be stuck in that position. So I would much rather know if the person wants to know something, because, as I said earlier, I don't want to get in this like, well, now I have something, do you want it or not? That's sort of coercive. So when we went back, as we did with a number of cohorts, there was a very high uptake on both data sharing and on return of results as separate concepts that I think the people understood. What we had a lesser uptake actually was on, do you want our newsletter?
So it sounds like context is important, and so if there's ongoing engagement with participants, that there should be a consideration for reconsent to address this component. And I guess I'll add one other question to that. Sometimes these happen tightly connected to clinical teams, and sometimes these happen in very epidemiologic, very separated from clinical research teams. And those groups may have a harder time garnering the counseling resources, the getting people kind of routine medical management recommendations. And so I don't know if that factored into it or not. It may be too nuanced and too specific, but I know that it's an area where some people still have questions.
Yeah, so the question of whether the research team can capably communicate the results, that's a real issue. My general sense is that people can garner the expertise that's needed, and frankly for free often, because these things will be rare. And so that shouldn't be an obstacle, that there should be people that they can bring in at their institution or outside of their institution that can help them. I do feel very strongly you shouldn't be taking over care of these people. You should give them the information they need and refer them to clinical care. So your obligation should be low, but you have to competently deliver the results in a way that are understandable to the person who's getting them, what is being given to them, and then what is the next step.
I don't think anybody, well, maybe I'm generalizing too broadly. There really is a tremendous difference between the clinician investigator and, the downstream epidemiology researcher. And I think people do believe that if the epidemiologist has a finding that he or she feels needs to go back to the patient, that information actually goes back to somebody more proximate to the patient than the epidemiologist. So, if we get a sample from the University of Washington and then some research that's done at Vanderbilt, nobody from Vanderbilt is going to call that person up and say, here's what the result is. So, but there is a lot of debate about I mean, some people would argue that all the downstream researchers have an obligation to get information back to somebody who is proximate to the patient. Others are questioning about how far that, how far that extends. So I just want to say that there actually is considerable debate about that.
Great. I just want to say thank you again to our panelists. Oh, we have one more. Good.
Can I ask one?
Yes, we do. We have another 5 minutes, so
Okay.
certainly.
So first of all, I'm Barbara Beer. I'm at the Brigham and Women's Hospital and Harvard Medical School. So I want to thank the panel for a wonderful session and day. But as I've been sitting here thinking about sort of how these general principles will be applied, and I understand our remit today is cancer and cancer trials. How do you think about the application of what you've discussed in terms of, let's say, sensitive research in mental health and other, sexual deviance and that kind of research where the information one may be sharing or the genetic applicability, while we're not there yet with actionable or identifiable genes, we are on the threshold of knowing those for schizophrenia and others. So how do you think about that? And then how do you think about applying the principles you've laid out today in the international setting, since after all, much of our research is multinational, in fact?
Well, I'm looking forward to the day when a lot of these mental health conditions are actionable. And right now, a lot of them are not. So if I would be thrilled to be in a position of being able to intervene to protect someone from having Alzheimer's disease or schizophrenia or some other condition. And I wouldn't consider that any differently. If there was an action that you could take that would reduce risk, then those results should be returned if the person wants them. And again, they need to understand what you're offering. There's actually some good research being done right now on how to consent people in broad categories of, do you want, things related to this? Do you want things related to that? So it's not do you want genetic results, yes or no, but do you want cancer-related results? Do you want, these other types of results? And I think it's going to be really important to understand the best way to get consent for that. But if people say they want them, then they should be given them. And again, I go back to the obligation to look, or excuse me, to return things limited to actionable. But if I don't have any issue, if a researcher wants to give a non-actionable thing back and the subject wants it, that's fine.
So Barbara, one thing I would say about this is this goes exactly to my process point, which is that I think as we decide, when the level, when something gets ready for prime time, either clinically as an incidental finding or a secondary finding, or in the research context, that these are not simply medical decisions, that they are actually broader social decisions, and there need to be more inputs than just what physicians think. And it may well be that what people want is much broader than what we think they're going to want, or narrower, or whatever. But I do think that this does call for a much more open process than what we currently have. I have to say that I suspect that if we found something that we could do that would avert the risk of Alzheimer's, that people would be breaking down the doors to get tested and to figure out what to do. So, or if people, and so I think, and if we thought that there was something to do with other mental disorders, that would actually do a tremendous amount to address the stigma that's associated with those illnesses. And I'm pretty sure most people would rather avoid that morbidity. So I think we have to have a much more open process for this going forward than we currently have.
Coupled with legal protections for re-identification and misuse of the data.
No
as you've been
question.
saying.
No question.
And the multinational aspect of
the
this?
multinationals, someone actually, I think it was Melissa this morning that made a comment about the European privacy thing. What's fascinating, they have, such a stark privacy law, and yet culturally, many parts of Europe are totally opposed to that. I mean, if you go to Scandinavia, they share their data all over the place for research. I mean, there's just unbelievably great epidemiologic research that goes on in Scandinavia because they are willing to share their data. So, so I think the challenges that that we'll face doing this work in a multinational context obviously have to deal with some of their different regulatory regimes, also some of their different cultural regimes about, the acceptability of research or not research. And then obviously in resource poor countries, ideas about, benefit sharing. I draw a blank on the word, going back to the CIOMS documents and others. So I think that that's going to, it is going to be a real challenge because there are different regulatory regimes, there are different cultural settings, and there are real different challenges between doing research in resource-rich countries like ours and resource more limited countries. But we've been doing that for a while. So, so I think we'll have to do that. But but I think we have some ways going forward. But I think it's really important thinking about the EU to realize that what their laws say and what they actually do, at least in some parts of Europe, couldn't be more different if you tried.
I know.
And we have one final question, I believe.
John Mendelson from MD Anderson Cancer Center. This has been very informative, but I have a question for the panel. I think more and more information is going to become available over the next decade of the type we're talking about that many of us feel ought to be related to patients. And in many cases, the information is going to be relevant to something different than the physician who is managing that patient has expertise in. Who should be relaying this complex information to patients, and who's going to pay for it, for the time, effort, and delivery of this message?
Well, cost is the thing that we just avoid talking about like the plague in this. And clearly, return of results is going to cost a fair amount. Not only the actual process of, what Gail was talking about in terms of interpretation about the kind of genetic counseling that she and others like her so exquisitely do, and for which there are insufficient people who can do it, but also all of the downstream costs that are going to follow as people try to follow up the results of what they want. We have to decide if those are costs that we're going to bear. I just think we have to. And so it's going to be a cost for our healthcare system. Certainly, as a clinician, as a law professor, I can say that if you are the one who returns information and you don't know how to interpret it, that means you have to refer to someone who can. Duty to refer is absolutely implicit in the physician-patient relationship. And so, so all of those things are going to be things that we're going to have to take into account as we think about as our policies going forward.
Well, we agree. You're going to have to CLIA confirm research data if you're going to make clinical recommendations. That's the law. The physician to whom the patient has come for treatment may know how to interpret the data, but they may be very poorly trained in how to manage an issue which could affect a family and could affect downstream things that they have just not a lot of experience managing. And we are just in very short supply of genetic counselors in this country. So I think it's an issue that I hope this report at least outlines must be addressed.
Yeah. Well, I'm a general pediatrician. Okay. I think at least some of this is going to have to come through information support, just like we get for pharmacogenetic testing at Vanderbilt. And just, in pediatrics, we've had this for a decade. When I admit a patient, I put in their weight. And so when someone orders a drug and it's a tenfold error, which is a problem in pediatrics, the computer sort of, melts down and says that's the wrong dosage for that child. So I think that we're going to have to get better about computer support, at least to alert the clinician to what the general issues are and to give them some idea about where to refer, because otherwise we're not going to know.
And so I'll pile on to that concept. I think informatics support, it's something that we're working on at University of Washington too, to help people interpret genomic information, because we're giving whole genomic reports in the medical record now, and lots of people are looking at those who don't really know what it all means, and so they need some support for how to interpret it. Certainly who to refer to, and I think you're right, there will be a shortage of genetic counselors for a very, very long time, and certainly medical geneticists, that we are the people who are trained to understand this information, and the education of general physicians is woefully inadequate and has not gotten appreciably better, in my opinion, in the last 10 years. So that's going to continue to be a problem. I'm in the position now where I say to patients, this is a variant of uncertain significance in a breast cancer gene. If a surgeon wants to remove your breast, tell them, Dr. Jarvik says, no, you can't. Because, the surgeons say, like, well, family history of breast cancer, change in breast cancer gene, that's not how it works, because the vast majority of those will be benign, and I know that, and you know that, but they don't know that, and I haven't been able to convince them of that yet. As far as the cost goes, I have to say, I really like the model of, send it to the clinic and let us get the CLIA test. The insurance companies have paid for those tests. I honestly see people, I've seen many people come into clinic with their 23andMe results, and the insurance companies are paying for those to be interpreted. So certainly if you come in with a highly penetrant pathogenic mutation, we can convince the insurance company to pay for that test.
All right, so I want to again thank our panelists, and we have time for a break at this point before our next session.